Good afternoon and welcome to Open Classroom. I'm Janet Gillow, Director of Professional Development for the Brown School, joined by my co-host, Assistant Dean Ryan Lindsay, who will be moderating today's Open Classroom. The session is being recorded and we're delighted to have you with us and want to hear from you. However, we cannot see your audio nor see your video nor hear your audio. So please do use the chat function for those of you joining us on Zoom for any questions or comments that you'd like to raise through this session. Today's session is one that I'm particularly excited about, but we'll get to that in just a second. But before we do, I want to share it's a particularly busy week for us at Open Classroom. We have programs today, tomorrow, and Thursday, working hard. Tomorrow, we will be launching the first of a three-part series related to Missouri Medicaid expansion. So we'll be on at 12:30 on Wednesday, and that first conversation related to Medicaid expansion is going to be on racial equity and Medicaid expansion. So if that's a topic of interest to you, please do sign up on our website to join us. And then we're back again on Thursday at 12:30. Chris Fry is going to be delivering a workshop on introversion and extroversion, social distancing, and quarantine. So if you're one of these people that has noticed we're going through the same thing, but we're not going through the same thing, Chris has got some thoughts on what's going on with us that makes us all experience this differently. So with that, I'm going to pivot our attention to today's program. Very delighted to introduce our speakers. My friend, Dr. David Patterson Silverwolf, is an associate professor at the Brown School. Before entering academics, he spent 15 years providing clinical services in substance use disorder treatment. He's a person who sustained a life in recovery since 1989. And David is part of the Dakota team developing tech tools to measure and monitor treatment performance. He's the director of the Brown School's Community Academic Partnership on Addiction, which is also known as CAPA, which works to bring performance-based practices to addiction and mental health services. And then later in the presentation, David is going to be joined by Ken Zheng. Ken is a serial entrepreneur with a strong background in software engineering. He's a WashU alum from McKelvey School of Engineering, graduating in computer science. He's co-founded 2 tech startups, as well as having software engineering and management experience for a global company. And you'll find out soon what that has to do with lessons from COVID-19, what the pandemic tells us about opportunities for addressing the opioid crisis in America. So with that, I turn things over to my friend, Dr. David Patterson Silverwolf.
Hey, thank you so much. And so I greatly appreciate this opportunity and glad folks could join us. And so let me say this presentation, this actual topic came together pretty quickly. But, you know, the stewing on this and the work on this has been going on for a long time. Just the idea of not having real-time, real-world data. It's been happening over quite some time. And so how we got here, and so several months ago, I was finishing a book, The New Addiction Treatment, talk about shameless plugs. And so one of those, and so this book is really about an industry that's guided by intuition. And so having been in the treatment service for a number of years before getting into academics, you know, I'm guilty of the same thing, is that our industry is basically built on intuition and gut feeling. And so the chapter on this, and so each chapter of the book starts with a story. And this particular chapter was about Dr. Benjamin Rush. And so Dr. Rush, his name is on our Declaration of Independence. He is considered the father of psychiatry. He was both an educated and religious man. And so he thought, or he was moved by and thought his work was guided by both the blessing and the wherewithal, where he was being totally directed by divinity, by basically God. So he was doing God's work. And so in 1793, there was a yellow fever epidemic. At the time, it was devastating Philadelphia along with other places. That's where Dr. Silkworth was. And he had this brand new treatment. It was called bloodletting. And so he had this theory that the fever in your body is caused by friction of too much blood traveling through your very small veins. And so he basically said, just like when there's friction of wood with wood can start a fire, wherever there's friction, there's heat inside the body because of too much blood traveling through your brain. It caused all this friction and it caused all this heat. So his solution was to relieve you of some of this blood. And so during this time, during the yellow fever, he was treating hundreds of people a day, which means he had a front yard, supposedly, that was soaked in blood and overrun with flies. And so I would imagine going into his office was quite a challenge or an experience. And so it wasn't until a local journalist began to review death records at the local morgue, and he compared Dr. Rush's patients with regular patients who didn't get Dr. Rush's treatments. And he wrote that basically Dr. Rush came up with one of those great discoveries which had contributed to the depopulation of the earth. And so it was only after that, only after data come about, that Dr. Rush was, I want to say, shamed out of his practice, but it began to end. And so as I'm writing and all this is happening, the COVID-19 hit, right? And so within a matter of weeks, we at the Brown School had a link sent to us from a colleague that showed these real-time dashboards for COVID. And so this is a screenshot of one of those dashboards. And so you get, and again, this was in a matter of weeks, you could see worldwide or in the United States, you could see how many cases there were. You could see deaths and recorded cases. So you could see that active cases over time. And down at the bottom, you could see test results by race and ethnicity. Again, death cases by race and ethnicity. And then cases by states. And this is just one screenshot. I could not capture all of these dashboards on this. The other dashboard, you could drill down by state. You could actually look inside of each state, look at cases and deaths, fatalities, who have recovered, and just the data went on and on and on. And so I thought, well, let's check out our opioid. We have another epidemic going on, which is the opioid epidemic going on, and let's check with our dashboard, and here it is. It's you can see the text here. The drug overdose data comes from the CDC's Wonder site, and there it says available data is currently from 2018, with 2019 data usually being released in early 2021. And so our opioid epidemic data has a 24-month lag time. So think about this, every state was awarded millions of dollars of funds to fight this opioid overdose epidemic. They pretty much had to wait 2 years to figure out what happened, right? And, right, so it just sort of in real time brought this whole idea of the lack of data within our epidemic, within substance use disorder, in general. So by law, as an academic, I am forced to publish things. And so, so it's pretty easy to do when I can become a little upset or something. I get my anger out in writing. And so the first article was on the left. It was in a journal, peer-reviewed journal article. And this, most academics, when they write things, they write it and make sure nobody ever reads it by publishing it in journals. But the other article that was written was in Stat News, and so they're associated with the Boston Globe, and they publish health-related data, and so I decided to publish there. And I've published there in the past, and most people hate my ideas, but this one seemed to resonate with folks. And so it made an argument on how the substance use disorder industry, specifically the opioid use disorder epidemic, how we can begin to leverage state and national data to inform folks in real time what's going on with this epidemic. And so just this COVID and these dashboards made me realize from top to bottom that our nation and states are guided by slow data. But on the ground in community-based organizations that treat addiction or substance use disorder, they are guided by no data. And so it is all intuition and gut feeling. And so imagine frontline therapists here in St. Louis have caseloads of 75 to 100, and we've worked with folks, organizations that have this. They can't answer any basic performance questions about their current caseloads or closed caseloads. For example, in their open cases, you pass a therapist in the hallway, and I've done this. I've asked them, hey, what's the demographic makeup of your current caseload, 75 to 100, on age, race, gender, diagnosis, like who is on your caseload? They have no clue. What quantifiable measures of recovery or treatment plan progress do you have? Please tell me, like, what percent of those patients on your caseload are actively moving in a sequential process towards their treatment plan, right? Treatment is about a sequence of events that leads to a conclusion, regardless of what that treatment is, whether it's cancer or any other illness. Treatment is about a sequence of events that leads to a conclusion. And there are no quantifiable measures of that in our industry. You can ask about attendance. How many of your current caseload are attending all sessions? There's no clue. How many on your current caseload are in that critical 2-week period in treatment when we know treatment dropout has the highest rates? And so we know that 50% of people drop out within the first 2 weeks of treatment. These are the very critical times of treatment. They really have no clue. And then you can ask them about closed cases. You can ask, hey, what's your overall success rate? That means who completed with staff approval? They really are not sure. What is your average retention rate, like the average number of days in treatment? This is very important. Just like high school, the longer you stay in high school, the more likely it is you're going to graduate. And we know from historical decades-old data that students who graduate from high school have better outcomes than those who don't. And that's the same with treatment. The longer you stay in treatment, the more likely it is you're going to complete treatment with staff approval. Those patients who complete treatment with staff approval have historical better outcomes than those who don't. But there's no real-time data that show therapists these. And then you can ask, which type of patients do best on your caseload? Age, race, or gender, right? Who do best? There's really no clue. And so at Kappa, and part of my academic career, we have captured performance data. And let me just say, when we do capture it, it's not good news often. And so here's this treatment dropout table. And so it asks patients percent of clients who leave treatment by week. And so the red line are white patients, and the gray line, I guess, is our minority patients. And so you can see after week 1, about 35% of white patients drop out after treatment, whereas 20% of minorities. Then you can see after week 2, it goes down a little bit, and then it tapers off until you get to week 4. Then after week 5, there's another mass exodus to where 75% of patients are gone after week 5. And so I get this question all the time. What explains, we know what explains the first 2 weeks. What explains this 4 to 5 week increase? And my theory is that in outpatient treatment, after 4 weeks, what new information do you hear? Right? What is there anything new going on? You know, most people will give you 4 weeks, but after five weeks, they might need to see season 2. And unfortunately, in typical outpatient treatment, season 2 never really comes. Retention, days in treatment, like I just discussed, it also has an equity problem here in St. Louis and in other places. You can see that non-minority folks have about half as long of days in treatment than white patients, which again, the likelihood of making it all the way to completion is a challenge. Then we ask frontline therapists, what are the, and these were about 400 therapists here in the St. Louis, Missouri region, what are the evidence-based practice, what are those practices that are supported in science that you use on a regular basis? And they listed those, and we found out that over 40% of them were not supported in any science. The rest were CBT and motivational interviewing. The other supported practices were CBT related things, DBT. They were peer reviewed, random controlled trial practices, but the 40% had none of that. And I'm happy to share some of those if you're interested. I get in trouble when I share those because these are practices that are heavily marketed and heavily anecdotal passed on, right? So there's a lot of pseudoscience that's used in our industry. Then we ask therapists, if you were trained on a new evidence-based practice, how likely would you be to use it if it was required by your supervisor, your agency, or your state? So here's the responses of therapists who said they would not use a new evidence-based practice if it was required by any one of those. So you can see if it was required by your supervisor, about 30% of therapists said, no, I'm not going to implement that. And so the others, 22% agency and state, there's still a cohort of 22% who said no. And so I tell organizational leaders all the time, if you want therapists to do something, you're better off saying that it's required by the agency or state. And even then, there's a cohort who will still not do it, even if it was required. And so this gets to the other part of that, is that we ask therapists what's more important to them, their own practice wisdom or an evidence-based practice. And about 26% said that practice wisdom is more important than new science, right? And so what I have just discussed here is that we have an industry that's based on all intuition, no data whatsoever. So it's, so with what fills that space is practice wisdom and folklore and pseudoscience, because what else do they have to be guided by? And so we look inside also of treatment organizations, just the composite of therapists and patient matching on age. We can see that therapists are a bit older. And so there are some mismatches on age. But then we go to race and gender. And we can see, if you can see my pointer here, I'm not sure. We can see that obviously it's a heavily female professional with a male patient. So there's a mismatch there. And there's some other mismatches here. White female again, mismatch. And so we have to ask ourselves, are patient inequalities, inequities baked into our treatment systems cake? That is, just our general practices, do they lend themselves to poor outcomes, right? And so the one practice that we use is caseload assignment. And so let's look here at therapists. We have 4 therapists. We have therapists A, B, C, and D. And on top of these therapists are their caseload numbers. Now, given these numbers, who might you say would be likely to get the next 5 patients being admitted into a program? And so if you said therapist D, you are correct, because the system is all about therapist caseload equity. It's not about what's best for the patient, it's what's best for our system. And so what's built into this, there's some assumptions that basically, and this is how I was trained, is that every patient has an equal chance at recovery regardless of whose caseload they're on. Is that trained and educated therapists can overcome all of patient issues, or regardless of age, race, gender, cultural backgrounds, whatever the patient brings, a trained and educated therapist can overcome that. And so a recent study we did began to challenge some of these assumptions and practices just on this case assignment. And we ask, does patient-therapist race and gender matching matter? And I think in our industry, I would say yes, right? So I was brought up in this industry. I would say, for instance, when a minority male patient is treated by a minority male professional, that's a good thing. That's the way it should be. There's some connections, there's some therapeutic alliance, right? And I think throughout our industry, that's what's said too. We need to, our professions should match the population we're served, that's being served. And so we tested this theory. So I got data out of electronic health record system. And so it was a large and multi-site substance use disorder outpatient treatment organization. And so I collected race and gender for both the therapist and the patient. And success was measured as completed with staff approval. So an electronic health record system, when a discharge, the reason for discharge, there's usually one good outcome, which is completed with staff approval. And there are several bad outcomes, which is left against medical advice, stopped attending, went to prison, relapsed, right? And so we looked at this one successful outcome. And so within our sample, there was a 23% success rate in this large organization that treated thousands of patients a year. And so we'll go through some matching real quick. And so what we see on the left here are therapists. So there are 4 different profiles of therapists: white male, white female, non-white female, non-white male. And here is the patient, a white male patient. So it's like we're going to see who does best with a white male patient. So this N is the number of matches. So there's a lot of white male patients. And so you see that the highest match was matched on with white female. But I would say in general, it was more heavily matched on race. And so usually when I do this in a large audience, I ask, who do you think did best with the white male patient? Have people raise their hands. Unfortunately, I can't see you. So in the way we were trained, if you're a therapist or a social worker, there should be no difference, right? Everybody should have an equal chance. Everybody, so this success rate, it should be equal. But here we see who had the best success rate was a white male therapist, right? There was a 45% success rate. So a white male patient who landed on a white male therapist had a success rate completed with staff approval of 45%. We see that the white female had 31, and then it gets much lower for the non-white therapist. The lowest was a non-white male. So a non-white male, non-white matching basically had 9%. So the next patient, what about white females, a patient? So in our industry, oftentimes it's preferred that females be matched with females for a numerous reasons. One being the if there's trauma or victimization in the past of the patient is more likely to feel comfortable with a female rather than having a male therapist. And so we can see here just the matching. Here, the greatest match was white female to white female. And something interesting we found was that the non-white male had 0 white female matches, right? And so people ask why, and I would say, first of all, there's not a lot of non-white male therapists. So maybe they decided to match on the important ones. We'll see that later. But even white male therapists still were matched with 94 patients. So who do you think did best here with the white female patient? The white male again, right? So 50% success rate, way over average. So the white female was the average success rate. The non-white female with the white female had a 2%, right? So, right, very low. And so we have no data for the other one. And so the non-white male patient, right? You can see the matches here. So again, it looks like the non-white male and non-white male matching was the largest one. And so who was most successful here? Again, the non-white male. Although the non-white male match only were 54, there was a 20% success rate. The non-white matching down and below 10%. And so the last patient profile, the non-white female, we can see here that the non-white female matching was the most. And again, the non-white male therapist did not have a non-white female match, which means in this whole study with over 4,000 patients, a non-white male therapist had no females on their caseload. Who did best out of this group? Again, the white male. Right, and so way above average. So I have presented these data for a long time, several times, and most of the time with social workers and therapists. And unfortunately, folks in the audience have sometimes been hostile, a little hostile towards me, to realize that the white male therapist outperformed everybody, and it was like they couldn't make heads or tails of it, and it was a bad place to be. So I'd like to take the same break here. This poor little guy has a heads and tails problem, so we need a little emotional break here to try to figure out what's going on. And so the main I think topic here is to express the idea of performance-based practice, and that good intentions is not enough. Just saying this is the way we've always done it, we have good intentions without having the performance as a result of that, it's not good enough anymore. Is that treatment without any real-time performance is the equivalent of Dr. Rush and bloodletting, right? We must demand that performance-based practices be embedded throughout our whole treatment system, right? It's the idea of show us your data, show us your value, show us that your patients have outcome equity, right? The burden should, sorry, I'm preaching a little bit. The burden is on the provider to collect and show their outcomes, right? There's an expectation, or there's a history that treatment centers, whether it's mental health or substance use disorder, it is always, there is a great need out there and we need to treat more people. We need more money to treat more people. And when it comes to any performance outcomes, there's always an excuse, well, we don't have money for that, right? We only need money for services. And it is up to the provider. It is the provider's burden to show their outcomes. Can you imagine giving money to treat COVID-19 and the organization you give money to is not able to produce any outcome information? This is exactly what addiction treatment is. And so in order to do this performance-based practice, it takes a village of programmers, right? Something that is not embedded or connected in these industries at all. But we have the know-how, we have the tools, and we have the technology to begin to incorporate performance-based practice into our care. And we also have Ken Zheng from Dakota, who's going to now show us their performance-based tools that address these shortcomings in our current system. So I'll turn it over to Ken.
Thank you very much, David. That was quite the sermon and also the lecture. Awesome. Well, really happy to be here, everyone. My name is Ken Zheng. I'm the CEO of Dakota, and David and I met about 3 years ago. And I mean, you know, the new ideas in this talk today were related to COVID, but I think he's been working on the idea of performance-based practice for nearly a decade. And so it's something that he and I truly, you know, hit it off on. And I am an engineer, a software engineer by training. And so I was ready to implement a lot of his ideas and try to bring it into the industry for substance use treatment. So I'm going to, you know, essentially show you what our tools do and how they're an example of performance-based practice and how it might be able to inform your practice or, you know, deal with real life scenarios that you might be faced with every day. So heading over to our program. So this is a program that has both a therapist interface as well as, or a therapist and clinical staff interface, as well as a patient/client facing interface. Oh, I'm not sharing my screen yet. Sorry about that. And can everyone hear me okay?
Yes.
Okay, great. So I will begin sharing my screen for our software. So this is the login that clinical staff members see when coming into the Dakota platform. So you see a list of your active clients, and you can create new clients, and you can see an overview of data about them. And remember that echoing off of what David said, that our tool that is built here is about solving problems, which is really focused on performance data in and outside of the treatment clinic. So with those caseloads of therapists that we've interviewed of 75 or higher, and the difficulties of a mental disease that is substance use disorder, that it's a very difficult thing to treat, and we're trying to create ways to make that easier to gather data and to inform your treatment decisions from the data. So referring back to some of his presentation, for example, the demographic makeup of your current caseload. We've worked with several EHR systems and looked at them, and often we find that this information is not readily accessible. So one of the things we did was we built out a graph view for the active clients where you can easily see the demographic makeup of your caseload. And be able to see that at a glance and hover over things so that you can really quickly, again, just be able to tell what the demographic information is. And we'll also be able to then, using that, inform the matching that David spent a lot of time talking about. And so the idea of what types of therapists are matched with what types of clients or patients is something that we look at in My Performance. So when you've come to My Performance, first, you look at just some preliminary data, like how many clients you've served total, what their average retention duration is, broken out by especially the first 30 days, because that's when it's the first, especially 2 weeks of this is when it's critical that you maintain clients. And so if you have a lot of clients leaving, within the first 14 days, that is typical for therapists in this industry, but it's something that perhaps a supervisor and you could talk more about, to receive more training on, or to really analyze why that might be happening. And then we talked about the completion reason as well, which, so here you see that 15 patients here have completed with staff approval, and then there's a host of other reasons why they did not complete, and that you can see the breakout by those different categories. Now, getting to the topic of therapist-patient matching. So we come to the advanced tab here. And this is the idea of looking at some pretty basic demographic information, but it can be very useful and insightful if used correctly. So for example, if we just have gender selected here, essentially it looks at all the gender breakdowns of the patients that you have served and how many have completed with staff approval. So down here it says, of the 23 total male clients you have treated, 8 have completed with staff approval, which means that your current compatibility score is 34% with male patients. This becomes more powerful if you select other factors to look at. And so here we'll just look at gender and race. And so then you can see that, for example, there were 3 total female and white clients that you have treated, and 2 of them have completed with staff approval. Now, 3 is not that many clients, so you would want a good, decent amount of data in here to really be able to start seeing the results. But you do begin to see some trends once you have perhaps 6 months worth of data in here, 3 to 6 months worth of data. Then you can begin really seeing how these different factors impact your ability to have that therapeutic alliance with your clients, or have the ability to really connect with them such that it impacts the way that they perceive the treatment that they're receiving. We've also talked about additional factors we want to include here, such as the primary diagnosis for mental diagnosis or for substance use, and maybe even what modalities you're using, or suggestions that we've received in the past as well, to see what kind of impact that has on treatment completion. So definitely more we want to do here, but this is beginning to sort of answer that question of how do you deal with therapist-client matching equity, and with dealing with improving outcomes based on the matching process. Now, this is a pretty longitudinal way of looking at data. We have a much more acute way of gathering data from the clients that the therapists are treating. And so that comes in the form of in-person and remote, what we're calling sessions. And so a session is the idea of a client coming into an outpatient facility or a treatment facility in general, and being able to receive treatment for those 50 minutes or hour. And so to create a new session, we're going to go down to my representation as a patient here, and we're going to add a new session. And so what you see here is a list of questions that we've developed in accordance with what SAMHSA has published as the 4 dimensions of recovery. And we're calling them the 4 vital signs of recovery. And this is like how, when you go to see your primary care physician, you expect just, very instinctively, they're going to take your height, your weight, your blood pressure, your pulse. That's something that you expect. That's something that the nurse practitioner or whoever's working with you, they expect to do that for your appointment, right? And they're gathering baseline data so that they can, show deviations as you come in for further appointments. Well, that's what our goal here is with these set of 4 questions around community, home, health, and purpose. These were derived from the SAMHSA 4 domains of recovery, as I mentioned. And so our idea and what we've implemented is to have patients self-rate themselves on these 4 categories based on the questions that you see here. And so you would choose from the dropdown. And so, imagine you're a therapist sitting across from the client or having the client use your computer while they're in your office, and they would be filling this out during that session. And so, as you can imagine, this begins plotting out, states of recovery that they're in. Whether that is a high point or a low point, you're beginning to capture that a lot more often than something like the daily living activities assessment, which to our understanding is only required every 90 days. And from what we've heard in practice is used even less than that. And so this is the idea of a lightweight recovery indicator that is meant to be used every single session that you have in person with a client. We've implemented this at one clinic in St. Louis last year with great results, which if we have the time, I'll talk a bit more about that. And so this, again, gets to the idea of gathering that real, sort of real-time live data from clients during that time. And it allows you to begin to see their recovery progress. And so we come over here to sessions graph for this patient. And over the course of January this year to April this year, you can begin to see what kind of progress I was making. Now, this is a very one-directional graph, which I think that the majority, knowing how difficult this line of work is, that a lot of journeys don't go as smoothly as this. But again, it's about being able to see and track that quantitatively so you can determine whether your therapies are having effect, what other environmental things in the patient's life are impacting their ability to recover. And this is something that David says to me all the time, that when someone fails in recovery of other chronic conditions, maybe like cancer or heart disease, generally it's not the patient that's blamed for their their inability to complete that treatment or to reach the success metric of being in remission from cancer or heart disease. But addiction is one of the few, if not the only field where the patient is often pointed at for not being able to complete their treatment because of a moral failure or a lack of willpower. And the stigma around that obviously is enormous. And also that I think, our message is that we want to equip providers with better tools to be able to see what they can do differently and how they can work with the client and patient better in order to not get to that stage where it becomes, okay, well, what went wrong and is the patient at fault, is who's at fault here, but let's figure out how to use this data to inform those outcomes and treatments better. So next, I wanted to talk about the idea of what we've done in response to COVID and to the telehealth movement that is spreading across behavioral health and substance use treatment. And so our first development was the idea of having remote check-ins, which is the idea of having the therapists then create these schedules of when they want to assess their clients. And so I'm going to go ahead and create a new schedule for myself. You go and select a date range. We're going to do Tuesday to Friday. And so that's this Tuesday to that this Friday. And we're going to do this Tuesday and this Thursday, for example, right? And so we're going to choose, right now it is 1:15, so we're going to choose 1 o'clock for that assessment. And then I can also choose certain categories. And these are categories that were, they were conceived by David and a team of researchers to be able to measure patient progress and sort of patient status. And so we're going to go ahead and select purposeful life and stress. And there's a list of these questions that you can have access to as well in order to inform, what you would be asking of the client. But then we go ahead and save this, and this is going to be a schedule now that, based on what I set. So for this week, on Tuesday and Thursday at 1 p.m., the client is going to receive a mobile assessment on their phone and in their pockets to be able to send you actionable data about, things that are going on in their lives. And so we're going to go over to my phone in a second to take a look at what that looks like. But before that, I'm also going to show you, before we hop over to the phone, we're going to show you what the telehealth features that we created in response to COVID look like, because that is one of the topics of our conversation here today. And so we're going to go ahead and start a session. And this is where we're going to see me many, many times now on the screen. But so I am playing the role of a therapist over here, and that's my image. And the client is going to be joining the call. The client, also myself, is going to be joining the call in a second. Before we do that, I wanted to just highlight that one of the things we've found about telehealth is that if you're using Google Hangouts or another solution, oftentimes you don't have the ability to do your work while still having that ability to see your client. And so we wanted to make sure that here you can go to schedule new check-ins, you can go see the client progress, you can still access all the other different parts of this patient's profile while still, in this case, waiting for them to join the call. But also if you were on the line with them already, this can just pop into the corner, it can be collapsed, but it still allows you to, see treatment options side by side with the patient's image and be able to have that telehealth session, which obviously has been greatly expanded amongst the COVID pandemic. So I'm going to hop over to my phone now and share the screen over there so that we can see what this looks like on the other end. So this is yep.
So we have just a couple minutes left.
Okay, great. Okay, so this is what the client and patient would see on their device. And so we have the mobile app over here. And so I'm going to go ahead and open that. And so they see a brief summary of what's coming up today. We have a check-in and a virtual session. So first we're going to go take care of that virtual session. So we're going to join the call with Mary Poppins, our therapist user. And now you see me twice because I am both showing myself as a therapist and as a client. And you have the normal expected controls down there, and you essentially can have that virtual session with your therapist right there from your smart device. Now we're going to go ahead and hang this up so that we can take a look at the check-in here. And so this is what the client would see for the questionnaires that they were assigned. And the way that we would implement this workflow is to essentially be able to, in a session, say, okay, well, we think, as a therapist, I've talked to you, and I think personal control and, in this case, purposeful life are things that we want to measure and monitor, because that's what you've brought up as issues, and that's what, you wouldn't say it like that, but, so this is, you've determined with your client what they should be measured on, and you've determined what schedule makes sense for them, and then they would be receiving these notifications and these schedules to be able to answer the questions. And there are 4 questions per category as they are designed currently. So they go ahead and slide all of these based on what they are feeling, and then they can submit that at the bottom. And they can also type an optional note in case they wanted to write something qualitative as well, in addition to the quantitative. Of course, our system is focused on quantitative data, but because we're dealing with substance use and mental health, there's a place for the qualitative as well. So we go ahead and submit that, and then we can head out of the screen. Now, the client also has their own ability to see their past answers, such as this one, and then they can see trends as well, which is something that we have been really focusing on implementing so far. There's not too much data here on this test client that I'm showing you, but they would be able to see their own trends just like you would be able to see their trends. And in this way, we really want them to be, coming alongside you for that recovery journey instead of it being sort of a one-way road. They can click on these and see more detailed trends in addition to exactly the average of their responses that day, as well as what they answered on that day, which is a pretty slick user interface, if I do say so myself. That pretty much covers the mobile app. And so I think, in terms of what we believe that recovery happens in the communities, not the clinics. And so if a client comes in to see you once every 2 weeks towards the end of their program, there's so much time and so many things happening in their lives during that time period that it would be a shame not to collect that data and be able to inform your practice with it. And that's really the point of what we're doing here, to develop essentially a digital safety net, a recovery network around this client that's focused on bringing you as the provider, as the therapist into the loop. But then as we expand, we want to also bring in perhaps their sponsor or their sober living community members into this recovery network so that they can catch up and check in with the clients as well. So I know I'm close on time, so I'll just sort of wrap up with the very last thing to say that we have implemented this inside a clinic in 2019, and if we have more time, I'm happy to share some of those results with you, and we'll have our contact information at the end here after David wraps up, and we'd be delighted to walk you through more of those options and our past research and data. Cool. David, back to you.
Thank you so much. So this is our first time, so we're still working out the timing of this. And so just final thoughts. And so rely on therapists' good intentions. It's unreliable. Performance-based practice is the key, and it's the future. Mobile is the future, right? And it's all about equitable outcomes. So we have to incorporate tech tools and collect and display real-time data in real time. And practices based solely on past experience or practice wisdom is dangerous, quite frankly. And case assignment could have ethical issues. So if you knew that you had a loved one that fit this certain profile, and there were therapists inside of a clinic, some of them had a 50% success rate with the profile of your loved one, and other therapists had a 7%, who might you choose? Well, the general public don't have that information, and they don't get to pick. And so the system of education, practice, and reimbursement has to be based on performance. This fee for service should be changed to pay for performance. There's plenty of tools, plenty of opportunities to do this. The Brown School is moving towards a performance-based educational model, and it's moving performance from the classroom to the community. And we just hope that the future does have real-time data, just like COVA, where we can all sort of benefit from these dashboards and these tech tools, and can be incorporated into our system of care. So thank you very much. This left a little bit of time for questions, and there's our contact information.
Thank you, panelists. I know I, for one, who was in practice for over 20 years, always wanted a dashboard so that I could follow along to compare, just to see where I was at in the context of the treatment, as well as progress for all my clients, but also to have some real-time data-driven access to decision-making. We've got several questions that popped up throughout the time. And I would like to lead it off with, Julie wants to know a little bit more about the study that defines success as staff approval. And how much does that reflect a biased system that's already baked into how we actually measure outcomes, even from that standard within that study?
Right, so I would agree, but that is one of the most reliable things, because at this program, it was done by the staff. So the staff got together and decided discharge outcomes. And so it wasn't just individuals saying, yeah, my patient is ready to complete or that. It was done amongst a team. And so the team decided that would be the discharge status. And then that was entered into the electronic health record system. Unfortunately, the EHR is the only and most reliable data capturing system that we have now. And so that's where these data come from.
Yeah, team-based decision-making as opposed to just a single person making that decision helps with that. Right. What about, so I was thinking a little bit about another question that came up. Sal is interested more about any insights for specific Latino or other racial and ethnic differences in the data. How can we use data? I think we can take that one step forward. How do we use data in that way to help improve equitable outcomes?
Right, so I would say if therapists do one thing very well, they collect lots of data. And for billing purposes, there's, data entry is required. And unfortunately, across systems, things like ethnicity and race are often, if they're in these systems, could be lacking. And so I think we need to do a better job at drilling down at that and making sure we get the complete data. And then we can see based off those good data that are interested outcomes. So I would agree. We have to start understanding the outcomes and the impact of treatment based off a whole lot of things: age, race, gender, diagnosis, all of those other kind of things.
Great. And Peggy's asking a little bit about, and I'm thinking about how customizable is this program so that you can ensure there's a client-centered approach to defining the outcomes.
Right, so I would say, and I didn't know this because I'm not a tech person, is that there's a whole process about developing technology that I wasn't aware of, where you actually go out and you ask the end users and those who are impacted by the technology, you gather all of their information. And Dakota has done a great job at doing this. They have a whole team that goes out and interviews therapists, patients, supervisors, leaders. And I know lots of technology, they could be seen as not being helpful, but we try to, and Dakota has really tried to develop something, a minimal viable product that can begin to start being leveraged in real-time service to at least begin to gather data and display that so everyone can see it.
Excellent. And I think our last question here is maybe speak to the advantages for organizations to be able to use this data. How can it help organizations?
Right. So I would say all the way down. And so I know a lot of organizations want to be the treatment of choice, right? And rather than saying, oh, we do this, so organizations, they do three things. They do what their website says, they do what they say in person, and then they do what they do. And so this allows the general public to say, okay, you say you do all these things, show your performance, right? And so it doesn't have to depend on the good intentions of saying, okay, I'm using evidence-based practices and I'm doing all these great things. We're culturally diverse, we're culturally sensitive. Show us your outcomes. That's where the juice is, right? And so treatment centers who have these data can put themselves out there as world-class. We're going to show our performance. And they can start to sort of be the leaders in this new movement of performance-based practices. And just my thoughts on that.
And really establishing the trust with the community.
Correct, because right now there's, you walk into a treatment facility, you have no clue what your outcome is going to be.
We are nearly at time, but before we end this program, which has gone just so quickly, and thank you, I want to give both David and Ken an opportunity to offer any final thoughts or closing comments to the group.
So I'll go first, Ken, if that's okay. Just quickly, I appreciate your time. If you want to learn more or continue talking, here's my email. That's the best way to get a hold of me. I'm a quick responder. If you have any complaints, you can send them to, no, I'm just kidding. Please feel free to reach out. We're excited about this. We hope folks take advantage of this.
Right, exactly. Send nice things to me and send mean things to David. That's what. But no, I definitely thank you everyone for your time. And if you want to learn more about, how to become that performance-based practice and how you might implement our tools in your practice, I think that's something we're definitely open for. And if you also are interested in being one of the voices that we talk to inform what sort of new things we're working on in implementing into Dakota, we also would love to hear from you and just get your thoughts over lunch, digitally over lunch in these times. So thank you, everyone.
Thank you both so much. So many positive comments coming in through chat of people seeing the possibilities in this, and sorry for all the questions that we couldn't get to, but you have the contact information to follow up on your own. Thank you, David. Thank you, Ken. Thank you to Ryan for being such a great co-host. Appreciate everybody's time joining us today on Open Classroom, and we hope to catch up with you at one of our other events coming up soon. We continue to add, so please visit our website for more information. Stay healthy and safe out there, everybody. Bye now.
Thank you.